eminent speaker, right from senior Dr. Saple as well as our panelist, Dr. Murlidhar Verma, with the upcoming generation who is trying to take up the torch in terms of managing HIV, with Dr. N. Shantanam from Madurai, Dr. Pasha from Nasik, and Dr. Sebastian from KMC Hospital, Mangalore. So, looking into the current set of the gathering of the most senior most people who have been the torchbearer for last 3 decades in HIV management, to the newer generation which is going to take it up and ensure that this once upon a time a death sentence is managed very well with the chronic manageable disease. So, not taking much of time, I'll like to introduce Dr. Saple, who has been one of the eminent speaker. Sir, can we put this slide? Sir.
Okay. Yeah. Okay. Sorry.
Yeah. Fine. So, who has been in pioneers and research and clinician in HIV/AIDS in India, who has been treating fluconazole 150 mg daily dosing since ages, consultant in dermatovenerology, leprosy, and HIV/AIDS, with his rich experience of more than 3 decades, as well as recipient of Lifetime Achievement Award conferred by IM in 2017. Sir has also been Lifetime Achievement Award conferred by Edivel in 2018. With this, I'll hand over the session to Sir, who has been associated with Bridge Candy Hospital, Mumbai. We have our panelist. Sir, over to you. I'll take a backstage.
Okay.
Yeah.
Thank you, Gajendra, and thank you, Hetero Healthcare, for arranging this discussion on the day where we should at least talk about the awareness and talk about the upliftment of the HIV and AIDS patient. Today, we are going to discuss about the ground reality of HIV and AIDS, where we have Dr. Verma, Murlidhar Verma, Dr. Anjali Sebastian, Dr. Santanam, and Dr. Pacha. So we are going to discuss what are the ground realities. We'll first start. I'll start with myself. I'll just give overall what is happening. Before that, of course, our panelist is Dr. Murlidhar Murlidhar Verma is currently at Kasturba Medical College, Manipal, where is a teacher for undergraduate and postgraduate student. He is involved in the patient care, is guide for the thesis. He is a medical officer of Hospital Infectious Control Committee in charge of HIV clinic. So we have Dr. Verma as a panelist, and of course, other 3 speakers also will be panelists. So talking about HIV and AIDS, where we have reached, what is the outcome of HIV AIDS? We started managing in 89. As a dermatologist, you will be shocked how we are come, but nobody was coming forward. We started managing, we used to admit 40 patients in a week, and we used to manage, and that's how we have learned the HIV medicine since 89. The first in 93, we attended the World Congress in Berlin. And what was the sentence? We are hopeful we'll have cure. And still, as far as cure is concerned, we are still hopeful. Anyway, but there are good things that are happening. One of the things is very important. What is the outcome of the HIV and AIDS meeting? That we have to now think of adherence, a long-term adherence of the patient. Secondly, long-term survival of the patient. You'll be surprised, my 3 patients are above 90, almost 200 patients are above 80. They are living normal life, good quality of life. Then about the stigma, still stigma is need to be minimized. Stigma is still not clear. That is still comes in the way of detection and the management of HIV patients. They have recommended HPV vaccine for every HIV patient. Then about the funding, unfortunately, funding is dwindling, is going down, and that is going to create the problem. They are expecting the death rate may go up if you do not get enough funding. There are certain policies we are preventing the stigma and the risk of resurgence. And If we do not get enough funding, there will be resurgence of HIV and AIDS, and we will not be able to fulfill our aims. That is that is supply 90, that is rule of 90-90-90, that it detect 90% the patient, retain 90% on ART, and suppress virus load in 90%. That will be difficult. If we go for the data, that still almost 40 million people are living, but compared to 2010, plus 25%, they are living with a good quality of life. The infection rate has gone down by 39% and death rate has gone down by 51%. So we are doing very well. Our aim is, as I mentioned, 90-90-90. That is detect 90%. So we have reached to 86%. Then retain 90% on ART, but you are able to retain in 77, and suppress virus in 90%, but at least 72%. So we have reached to that stage. But the finding of this meeting, the World Congress, that now we are worried. There is there is resistance to dolutegravir. Almost they say 4 to 8, 39 to 8.6%. There is resistance, and that is we are concerned, and that is the worrying point, because that was one of the drugs is a more effective, robust drug among the inside, but unfortunately now they have noticed resistance to dolutegravir. So what is the goal of the antiretroviral therapy? We know that to maintain and restore the health of HIV patient, minimize the adverse effects of the therapy, and HIV ART should be accessible to each and every patient living with HIV, and prevent transmission to HIV by any other route. So about ART, when to start? You start ART at any stage. There are about 35 approved molecules are available. Initial regimen, they said it has to be integrase inhibitor. That is a WHO recommendation. And of course, if there is virological failure, add two new drugs, but they have to be active drugs. So these are the guidelines about it. Now still we are getting new molecule. And of course, new molecule depends upon the actions, the multiplication, whether it is at the envelope, at the enzymes, glycoproteins, or RNA. It depends upon that. So one of the new molecule is available as a cabotegravir. Cabotegravir is available now, but not in our country, but it is to the patient who has got undetectable ART on ART without history of virological failure, without any drug resistance, or without any chronic HIV infection. These are the patients, they are eligible for cabotegravir. That is FDA approved. Another drug is called HIV capsid inhibitor, that is lenacapavir. But again, if you see, the lenacapavir is approved by FDA, but it has to be given to the patient who are heavily treatment experienced. HIV cannot be successful treatment with the other available treatment due to resistance or intolerance or safety. These are the patients should be given lenacapavir. Lenacapavir usually is given orally once daily or once in a week, but injectable is given once in a 6 month, 2 injection a year. And another wonderful thing about lenacapavir can be combined with the other drug like islatravir, can be combined with the broad neutralizing antibodies, can be combined with the cabotegravir, can be combined with the bictegravir, which is available in our country for last 6 years, more than 6-7 years. And there are still new molecules are in clinical trial, like a maturation inhibitors and broad neutralizing antibody. These are the things. There are many. Islatravir is one of them. And so these are the new molecules. Of course, now oral things are available. Now we are getting injectables, that they will come, will have implants, and they will come, will have patches. So these are the futures for the antiretroviral therapy. Of course, our expectation is very high. Now we reached to the long-acting ART, that is twice in a year. We are looking for broadly neutralizing antibodies, and of course, we are looking for the remission with the combined with the immunotherapy, cure in vivo and in vitro, and of course, in a cure with single dose. So these are the expectation. We are hopeful, and I'm sure the day will come, we'll able to reach, because the day was there. Patient used to die. We have seen in 93, 94, patient used to die with opportunity infection. We were not able to diagnose opportunity infection. And I would like to mention here, we are even in dermatology, we used to admit, and our first research was the Indian patients, they were dying of tuberculosis, not about PCP or Kaposi sarcoma. Everybody was talking about PCP. Those were the problem of opportunity infection of the Western world. Of course, then we did a lot of investigations. So now, Dr. Verma, Dr. Anjali, Dr. Santnam, and Dr. Parth, all of you are there? Hello?
Yes,
Hello?
sir.
Yes, sir.
Yes, sir. Yes, sir.
Yes.
Yeah. So we'll start the case discussion. So I would like to read the first case. This is a 50-year-old male patient diagnosed HIV-1 in 2014 during a routine checkup. He was asymptomatic, no comorbidity, only history of non-Hodgkin lymphoma in 96, no history of tuberculosis, herpes zoster, or any other OI. Blood transfusion was given in 96. Known case of MSM. CD4 count was 201. Percentage was 20. Virus load was 17,000. That time we started this patient on TDF and efavirenz based therapy. The patient was in 2000 November, that is on April, patient was doing very well. But in 2016, he developed nephropathy. Of course, this nephropathy is because of tenofovir. So now, Dr. Verma, what you would like to do in this patient? How we are going to change this ART?
Sir, I'll ask my PGs to answer, I think. I'll just
Okay,
moderate
doesn't
it.
matter. Yeah, anybody,
Yeah.
okay.
Yeah.
Okay,
Can ask Anjali
Anjali.
or others can moderate. I mean, they can answer.
Okay, Anjali. Okay.
So I would like to know how much is the creatinine of this patient and whether he had any other side effects. Was there RT associated with tenofovir?
No, this creatinine, I don't remember, but it was high and there was a glycosuria.
Okay.
Plus,
so then we can, because he's widely suppressed also, we can
Yeah.
change tenofovir to abacavir based regimen, provided that he doesn't have any hypersensitivity testing is negative.
Change it to?
Abacavir based regimen.
Okay. I entirely agree and we followed your advice. So we switched to abacavir. Of course, those days HLA-B 5701 we were not practicing, but nowadays anybody changing, we have to get that enzyme test done. Do you agree with that?
If the testing is available, then we have to go ahead with the HLA-B 5701 testing.
Yes, correct.
Because
Nowadays we get it done before starting. But this patient, after starting, he developed dyslipidemia. So I'll ask now Parth. Parth, how we are going to further manage? Dr. Santnam? You have to tell what you are doing in your clinic. That's what we want.
I think once started again, no need to change again, coming back to better. Patient is comfortable, you'll continue with the same regimen yearly. Otherwise,
With statin?
statin based on that age, sir. Anything above 40, recent guidelines favoring for even ACVD score, you check it. If high, you consider to start.
Okay.
Not for all patients, everything you
Yeah,
need.
but see, efavirenz is known for giving to dyslipidemia. So we changed it to dolutegravir. we changed it to dolutegravir, and patient was doing very well. It started in 2014, 2019, but he started getting weight gain. So now, anybody wants to address this?
Yes, sir. I am going to present same case only. Obviously,
Yeah.
it will be okay.
Okay.
Anything you want to for weight gain purpose, you want to change regimen, it's not acceptable. I think only few things only is there that I'm going to address also.
Okay. Okay.
I'm not favoring to changing any other regimen. You better you continue instead of changing other regimens.
Okay, okay. Anyway, that time during 19, there were a lot of articles. Weight gain is almost 10% weight gain is because of dolutegravir. So this bictegravir was a new molecule available. So we changed it to bictegravir. I changed this patient to bictegravir because those days bictegravir was not known to increase the weight gain. And then we observed for 2 years. 2 years there was no weight gain. And in fact, we published the paper that you switch over to bictegravir, and at least next 1.5 years to 2 years there is no weight gain. But after 2 years, I realized even bictegravir also patients started putting on weight gain, but the number of patients putting on this weight was less compared to dolutegravir. Of course, this you are going to cover, so I'm not going to highlight it. So now I'll go for second case, very simple cases. These are all practical purpose I have selected. 14 years old male patient has HIV infection from since 2000, comorbidity, diabetes mellitus with hypertension, patient on ecosporin, atorvastatin, digoxin, and Udiliv. Patient was admitted for breathlessness, pedal edema, weight loss from September 2022. Patient was diagnosed with acute heart failure, metabolic acidosis, and dilated cardiomyopathy. His CD4 was very good, percentage was 18. But if you see the history, from the history, patient was put on D40 in 2006 up to 2013. Then he was switched over to AZT. Then tenofovir 3-TC and nevirapine. But again, this patient had induced nephropathy and virological failure in 2017. So then again, this patient was started. This is the history, abacavir 3-TC and atazanavir, because there was a failure with the nevirapine. Yeah. But abacavir was given. Then this patient was switched to dolutegravir, atazanavir. Of course, abacavir can cause this cardiac problem. Then again, abacavir 3-TC atazanavir started. So this is how the patient came to our clinic. Even it can, this type of patient may you get in your clinic. So how you are going to manage this? Dr. Anjali?
So I would like to know about his CD4 count and HIV viral load status. Is his
Yeah, see, when the patient came to us, that data was not available. The initial CD4 count was 438 and percentage was only 18. But you would like to continue abacavir 3-TC atazanavir in this patient?
I would probably change abacavir because it causes dilated cardiomyopathy. I would probably change it.
So this patient should not be continued, no? Correct,
Yes.
no?
So I'd probably change it to, but I
so
don't know
you
about
would
the
like to
creatinine.
you would like to go back to dolutegravir and atazanavir, or
I would like to give I don't know about the creatinine station. Assuming if his renal dysfunction is not there, then I would like to give tenofovir, lamivudine, dolutegravir based regimen.
tenofovir, lamivudine, and
Okay, but he had TDF induced nephropathy before. Okay.
no, can you say loudly?
He had the tenofovir induced.
And
I think TLD would be an option for him, but because he had tenofovir induced nephropathy,
Yes.
Probably we can try for TAF if there is not much of contraindication, but I don't know his creatinine and creatinine status at this point.
Suppose now his creatinine is normal.
I would like to try with TAF and dolutegravir-based regimen.
Yeah, tough and dilated. Okay. Yeah, it's okay. But in our clinic, as you said, that was on the card where we started on the bictegravir, and the patient is doing very well with the TAF and bictegravir. The reason being, we started on bictegravir instead of dolutegravir. Reason being, there of course, last few years there are cases of patients are developing resistant to dolutegravir, and the resistant testing the patient
Thank
is
you.
already not possible. Then better to shift to the bictegravir. That was our idea. So we stick to, as you advise, TAP, FTC, and instead of dolutegravir, we give bictegravir in this patient. Now we'll go for the next patient. 55-year-old patient was diagnosed HIV in 2000. Started on D40, about those days, D40 with, of course, he was diagnosed with the pulmonary COX. Along with ATT, we started with efavirenz-based therapy. Yeah, 2003 patients switched to AZT, 3TC and efavirenz because D40 is known for the lipoatrophy. So we switch over to AZT. Of course, AZT is also known, but those days only AZT was better than D40. 2006 CD4 count is very good, 498, and due to the CD4 count is only 98%, is very less, 6. He had an immunological failure, so we changed AZT 3TC to indinavir, but because those days there was hardly any resistant testing and the patient could not afford. And we maintained this till 2009. But in 2009, if you see here, CD4 count was 169%, was 13. But CD4 count was not increasing. So instead of indinavir, we added atazanavir. But again, if you see the CD4 was, yeah. Yeah, so CD4 was still not increasing and there is virus load 3023. So again, that time we could do resistant testing, and the resistant testing to there was resistant to all PI. But that time darunavir was not available, and there was resistant to all NNRTI, whatever is nevirapine and efavirenz. And then patient started with tenofovir, FTC and darunavir. Patient did not come to follow up to 2016. See, 9 to 16, almost 7 years, he was doing very well on darunavir. But when in 2016 he came with a dyspnea, pedal edema, abdominal distension, melena. Of course, we diagnosed a case of liver cirrhosis with portal hypertension, treated with aldactone, Eduleve, stop alcohol. He was alcoholic. 2017, he was asymptomatic. Virus load was completely separate. CD4 count was very good. We continues tenofovir, FTC, darunavir. 17, again, if you see, he is doing very well. In 18, he developed bone toxicity and renal toxicity. So of course, we had to change tenofovir to TAF. So in 2009, patient is asymptomatic, CD4 count is good, virus load is doing very well. So now the question come about the cost and the pill burden. So Dr. Santnam, you're there?
Yes, sir. Please, sir.
Yeah. What is your further management in this patient? Because he is doing very well. We are following this patient since 2000, so last almost 25 years. But he said, now I can't afford darunavir, and there are too many tablets.
Virally suppressed patients, I think,
Yeah, it is virally
recently,
suppressed. Correct, yeah.
then we'll switch out to even nowadays. There will be no current concept is you will switch out to monotherapy even.
Pardon?
But that time I don't. No, no, sir. At present, what I'm telling, there will be
Yeah.
virally suppressed patient.
Yeah.
Even will switch out to monotherapy at present.
Monotherapy
For this patient follow, maybe consider.
or monotherapy?
Yes, sir. Even monotherapy, even double
No, you mean
single drug.
two drug therapy. Oh,
Yes,
dual
sir.
therapy. Okay, two drug therapy. I agree with you. So we can switch her to two drug therapy because this will be the ideal case because his viral suppression is all the time there. Correct? Anjali, what is your suggestion?
Yes, sir. We can switch to a dual drug therapy, sir.
Yes, correct. So we can switch her to dual drug therapy, but this patient was said we explained about the dual drug therapy, and I'm practicing dual drug therapy since 2017, almost last 8 years. We explained to the patient, but patient said no, make it sure that whatever you give, it should not create any problem in the future. So he was not ready for dual therapy. So what he'll do? Dr. Verma?
What about Insti, sir? Shall I ask?
Pardon?
What about Insti? Insti, any drug will add it to dolutegravir.
Yeah, that's what I want. So we can give Insta, no?
Yes, sir.
We can give that. That's right, correct. So this patient again started on bictegravir. Almost I'm treating with the bictegravir this patient for last 6 years, and these patients, of course, they are doing very well. You could have started on dolutegravir also, but I'm little bit worried because of the resistant testing and dolutegravir resistance. So that's why we have started this patient on bictegravir. Now, I think the last case is a 50-year-old male patient presented with the low-grade fever, loose motion for last 1 to 2 months, loss of appetite, weight loss, comorbidity, that is hypertension, no history of COX or herpes zoster in the past. Investigation done in June 25. Hemoglobin was very low, ESR was very high, virus load was more than 6 lakhs. USG abdomen, no lymphadenopathy. Upper GI shows the esophageal candidiasis. Creatinine was normal, LFT was normal. How do you manage this case? Dr. Parth, you're there or no?
Yes, I am there, sir.
Yeah, please.
So
Because yeah.
looks like he's a naive patient.
Yes,
And
correct. Absolutely.
now, and since he has come up with loose motion gastro symptom syndrome,
Yeah.
I would like to do his routine X-ray
Yeah.
and USG abdomen
Yeah.
and maybe a detailed clinical examination. I think
Right.
USG abdomen is normal. There is no lymphadenopathy, and since he has esophageal candidiasis, he has been since a very long time with HIV.
Yes.
So with this gastro syndrome, I would
Mhm.
like to check his stool for crypto, isospora, and all OIs.
Yes. Yeah, absolutely.
And
Yeah.
yes, sir. And first, I would like to rule out all the OIs possible for his
Mhm.
case. Sir, CBC, we have CBC, sir.
Yeah, CBC, the hemoglobin was low.
Yeah. Yeah. Okay. Yes. Sorry, sir. I'm unable to see it currently.
Yeah, no, what he says, right? We have to get it all this done before coming to conclusion. Dr. Anjali?
So I would like to evaluate for the opportunistic infections because he has loss of weight and predominantly GI symptoms. Again, opportunistic parasites causing diarrhea has to be ruled out.
Yeah.
Also, viral infection like CMV, colitis, HIV, enteropathy can also present with loose stools. So I would like to evaluate for all other opportunistic infections prior to starting him on ERT.
Okay. So, yeah, and Dr. Santnam, this patient, then we did HRCT, shows non-necrotic mediastinal paratracheal lymph nodes, but they were few centimeter size in size, and there was some lymph node in the small bowel, mesenteric, paramesent, and para-aortic regions. So now, what you will think of?
No, there will be always HIV patient. There will be possibility. Don't fix around tuberculosis alone. Even in non-TB mycobacterium, also possibility is there. Even histoplasma, you need to consider. The problem is your size. The sub-centimeter means always there will be problem.
Yes.
Yeah,
Yeah,
and the
small
locations
size,
are
they are
very
small size. Yes.
Sub-centimeter always problem. Better. What I will suggest, if biopsy is there, it's better thing. Other option you need to consider bone marrow biopsy also. If at all not possible, we'll go for empirical ATT only.
Yeah. The patient is not ready for the biopsy, or the biopsy is not possible then?
Then definitely even consider bone marrow. Bone marrow, if not possible, we'll go for empirical ATT only.
Yeah,
Last.
empirical ATT.
Yes, sir.
Yeah, why ATT? I like that idea, but why ATT?
Even non-necrotic, we can't consider non-TB. Even still possibilities there, sir. Even necrotic alone, we can't tell tuberculosis. Don't fix it like
Yeah,
that.
correct. But usually in tuberculosis, you get necrotic, no? See,
Yes,
we
sir.
are practicing for almost, you can say, almost more than 30 years. Our experience, you know, what is the first possibility? As you said, the first possibility anybody comes with the HIV, first possibility is the tuberculosis. Correct, you know, our country. So you have to
yes, sir.
think of tuberculosis, but they are non-necrotic. Of course, with our experience, when the patient is not ready for yes, doctor, who wants to add something?
I think sorry for this. Some sounds is coming. No problem. You continue, sir.
Okay. Anjali would like to add?
So I would like to establish a diagnosis because like prior to starting empiric ATT, as far as possible, I'll try to establish a diagnosis.
Yes,
so if
correct.
stool evaluation is negative, I'd like to send a CMV viral load, get a colonoscopy
correct.
done.
But all patients are not ready for all these or situations such their things are not possible. We have to use our clinical acumen. Correct? You agree?
Yes, sir.
In the institution, I entirely agree. We have to get it done. As Parth said, we get, But you know, with our experience, we have seen large numbers of patients. We used to admit 40 patients in a week. You'll be surprised, you know, how many cryptococcal meningitis we must have treated. 250 cases of cryptococcal meningitis we have treated. We should just admit cryptococcosis. Yeah, I'm talking about 93, 94, 95, because nobody was interested. No medicine doctor was interested. They were scared of HIV. Anyway, that's how we have benefited. We used to do postmortem. You know, what is the first research we did it? Indian patients, they were dying of tuberculosis. We used to do postmortem ourselves. And we proved by doing postmortem, they were dying of tuberculosis, not something else. That was our first research. That's how we learned TB. So TB was the main opportunity infection in India. Anyway, so according to our clinical things, patient was started on the antiretroviral because this is in the primary HIV infection. You can get this infection. Even Dr. Parth said esophageal candidiasis, you have to think of the chronic. I entirely agree with him, but this is seen in primary HIV infection also. But I like that your thoughts, esophageal candidiasis means you have to think of the chronic, but it is seen in few cases of neglected cases or the patient who are not diagnosed. they get esophageal candidiasis. In fact, I would like to mention that is in 95, I saw one doctor who was doing MS. She was admitted for diarrhea and she developed oral candidiasis. I was called, and like an immature person, when I saw her, I said it looks like HIV related candidiasis. Her father was physician, mother gynecologist. Mother shouted at me. Then I said, I'm sorry, because we should not talk, no, but we were also immature. That she said, are you sure it's HIV? I said, clinical things are suggestive of HIV. We got HIV test, it was negative. That time Western blot tests were not done in India. And one person was doing research, so we sent for Western blot, but he said we have got limited primers and that primer is not showing. They said, still you are insisting? I said, I'm sure about these clinical things. They went to USA and it was positive, and the outcome, she is married, she is practicing as a surgeon, and now they have got a child which is going very well. Of course, that time we started deportity, so she has got lipoatrophy. Anyway, coming back to this, so we started this patient on Tafic. You know why we started on Tafic? Why you have not started other antiretroviral? Anjali?
So it has lesser incidence of renal involved nephrotoxicity with TAF has lesser incidence of proximal RTA when compared to TDF.
Yeah,
So-
that's one of the reason. Yeah.
Other thing is currently it is integrase based treatment is recommended as the first line under NACO also.
Yeah, but
So
why
this
it is
particular
recommended?
combination-
I agree with you, but why it is recommended?
It has a much faster clearance of HIV viremia as
yes,
compared
correct,
to
correct.
efavirenz or NNRTI based regimen. So
Correct,
it is
of course. Yeah. Of course, we have to use because the virus load is 6 lakhs. So we are, and this is the we diagnose is a HIV related, is a primary HIV. So the primary HIV is better to give the robust or the more potent antiretroviral, and of course is the insta. That's why we have started these patients on Tafic. Of course, we have to be careful about immune reconstitution, that we have to keep. Yeah, we have to keep it in mind, and that was the reason we started. Of
So
course, we could have started. Yeah.
Sir, we have 3 more cases to go, sir. It's
Yeah,
already
finishing 2 minutes.
those cases, sir. We need to
Yeah,
discuss.
yeah. Finishing. No, this is 1.5 hour now. I'll just finish it. Yeah. So this patient is doing very well. Well, of course, viral load has come under control and CD4 count is so. Now I'll stop it here. Thank you very much, and we'll switch over to Dr. Anjali's cases. Anjali, you can start your. I'll
Sir, you
stop
can
it.
unshare so madam can upload.
Yes,
sir.
yeah.
Yeah.
Anjali, you can upload, make it a short presentation, okay?
Yeah.
Okay, sir.
Yeah. We'll discuss it, end of it. Probably if you have any questions, you can ask. Briefly, you present.
Okay, sir.
I'll give you
Good
10.
evening. I'm Anjali. I'll be presenting a case. This is a 65-year-old male who's a farmer from Davangere. He was diagnosed with PLHIV-2 in 2018, where he was initially started on tenofovir, emtricitabine, atazanavir, ritonavir combination. But in view of poor compliance, he stopped his medication after taking it for almost 1.5 years. He then presented to us in November 2023, where after evaluation for OIs, we had started him on tenofovir, lamivudine, dolutegravir. Subsequently, in March 2024, in view of tenofovir-induced RTA, we had changed to abacavir, lamivudine, dolutegravir-based regimen, with which he was taking with good compliance, and his CD4 done in November 2024 was 429, and HIV-2 viral load was undetectable in November 2024. He's also type 2 diabetic on medications. So he came to our center in October 2025 with complaints of cough for 2 months, which is associated with minimal expectoration. There was no history of hemoptysis, postural diurnal variation, no history of breathlessness or wheezing, no history of any pleuritic type of chest pain, no history of preceding rhinitis or URTI symptoms in the family. There was no history of palpitation, syncope, angina, and no history of atopy allergic symptoms. Along with the cough, he also had lower back pain for the last 1 month, which was predominantly mechanical in nature, which increases on exertion and relieved on rest. There was no radiation or migration of pain, and he also had a loss of weight of 13 kilograms over the last 1 month. There was no history of fever, no history of headache or altered mental status, no history of abdominal pain, urinary or bowel complaints, no history of joint pain, oral ulcers, hair fall or rash, no history of bleeding manifestations, no history of travel, and no history of intake of Ayurvedic or homeopathic medications. On examination, his vitals were stable. There was pallor, but there was no icterus, clubbing, cyanosis, lymphadenopathy, or edema. There was oral candidiasis. Respiratory system examination revealed absent breath sounds in the left interscapular, infrascapular, and infraaxillary areas on the left side. Cardiovascular, abdominal, and CNS examination was within normal limits. Musculoskeletal examination showed spinal tenderness over the lumbar region. On investigations, he had severe anemia. HP was 7.6 grams per deciliter. He also had a leukopenia with a total WBC count of 3,900. There was low platelet count of 104,000. Peripheral smear showed nomocytic anemia with no evidence of hemolysis. PT-APTT was normal, LFT was normal, creatinine was on the bottle was normal 1.05, but he had past history of elevated creatinine of 1.5. His CRP was elevated at 62.5. His urine routine was normal. Serum CRAG was negative. Brucella SAT was negative. Blood culture showed no growth. Autoimmune workup in the form of ANA and ANCA was also negative. His chest X-ray done showed a left-sided pleural effusion. And MRI whole spine done showed a spondylodiscitis with an intraosseous abscess in L2 vertebral body, with some involvement of the L1 vertebrae and also L1 vertebral body and extension to the prevertebral space, with an evolving abscess or myositis of the left iliopsoas muscle also. This is a CD4 and HIV viral load. As you can see, in November 2024, when he was on the abacavir lamivudine dolutegravir based regimen, his CD4 count had improved to 429 and HIV2 viral load was not detected. During this admission, his CD4 count had dropped to 228 and HIV viral load, which is not available initially during the initial part of the admission, but subsequently it came out to be 63,616. So summarizing, this is a 62-year-old male who is PLHIV2 on abacavir-based regimen with abacavir lamivudine dolutegravir with immunological and virological failure, who is a type 2 diabetic who presented with problems of left-sided pleural effusion, lumbar spondylodiscitis, significant weight loss, and pancytopenia investigations. So what differentials would you like to consider at this point?
Yeah, can you tell what differentials are you thinking at this moment? And we can ask others also.
So we were thinking of disseminated tuberculosis. Other differentials that we considered were atypical mycobacterial infection in the form of MAC, cryptococcosis, histoplasmosis. Pyogenic spondylodiscitis also considered because he was a diabetic with uncontrolled sugars versus a non-Hodgkin's lymphoma.
Did you think of non-Hodgkin's?
Because he had a pleural effusion and spondylodiscitis, and because of that the effusion and the spine involvement, we thought significant weight loss.
With collection, will you think of non-Hodgkin's?
Unlikely, sir, but much lower down we had kept it as a differential.
Yeah, Anjali, NHL is usually come with a lymphadenopathy. You get the large lymph nodes. Yeah, that is the one of the present of NHL. NHL is very after tuberculosis in the malignancy, the common malignancy in HIV, what it says is the NHL, but you get lot of large lymphadenopathy.
Yes, sir. This patient we didn't get a CT thorax, abdomen, pelvis at this point. So we couldn't, ultrasound abdomen as such did not show any intra-abdominal lymphadenopathy. Clinically, there was no peripheral lymph nodes also palpable. But because he had this pancytopenia on the peripheral smear and because he had this effusion, I would like to consider non-Hodgkin's lymphoma, but much lower in the differential.
Fair enough. Go ahead, I think. Go ahead. We'll discuss it.
So we went ahead with the diagnostic pleural tap. The total WBC count was 260 cells, which was lymphocytic predominant. Glucose was 82. Protein was 4.87 grams per deciliter. The serum protein was 7.2, which showed which is fulfilling Light's criteria. LDH was 260 units per liter. Cytology was negative for atypical cells. Fungal smear and culture was negative, and aerobic culture showed no growth. We sent the pleural fluid for Gene Expert, which though AFB was negative, Gene Expert came as MTB detected trace. Because of the trace called, the rifampicin resistance was indeterminate. Midget cultures were sent, but the report was awaited. Sensitivity for gene expert for pleural TB is around 25%, but specificity is around 100%, in view of which we consider this as a true positive result. So we diagnosed this patient with disseminated TB with pleural involvement and spondylodiscitis. In hospital, we started him on HRZD 100 dots, but on HRZD he had further drop in the total WBC and platelet count. So what are the possible causes of pancytopenia? So in this patient, because of pancytopenia in an RVD patient, these are the possible differentials that we considered. So first we thought whether there could be a bone marrow infiltration or replacement, either because of an infection or because of leukemia, malignancy or MDS. So infection possibilities, we thought probable HIV like HIV or CMV itself involving the marrow, bacterial infections like TB or MAC involving the marrow, fungal causes like histoplasma cryptococcus involving the marrow. Other possibility we consider was whether there was a bone marrow failure because of a nutritional cause, was aplastic anemia, medication related or HLH, for which we worked up, versus a peripheral destruction or sequestration, which was immune related or because of hypersplenism. So for nutritional causes, when we evaluated, we found that his iron, B12, folate were within normal limits. We worked up for HLH. However, he had no fever spikes in hospital. Ferritin, LDH, and triglycerides were within normal limits. Serum cryptococcal antigen was negative. CMV viral load was negative. Ultrasound abdomen and pelvis showed normal steady without any splenomegaly. So at the end of this evaluation, the possible causes that we considered was TB with a bone marrow infiltration versus a drug-induced pancytopenia because of rifampicin versus an HIV-2 related pancytopenia. So we went ahead with a bone marrow study with the aspirate and biopsy showed a reactive cellular marrow. Fungal smear and culture was negative, AFP gene expert was negative, and aerobic culture showed no growth. All this was suggestive of peripheral destruction. In view of the ART failure and presence of cytopenia prior to the HRZD initiation itself, we thought most probably this is an HIV-2 related pancytopenia, which was further worsened by rifampicin. So at this point, we got the HIV-2 viral load, which was 63,660, while the patient was on ALD, in view of which we diagnosed him with virological failure, and ART was changed to abacavir lamivudine with double dose dolutegravir with darunavir-ritonavir based combination, which is also BD dose. So when we looked at drug interactions, we found that darunavir as well as ritonavir had drug interactions with rifampicin, which is actually contraindicated. So in view of which rifampicin was stopped and the regimen was changed to with levofloxacin based regimen with isoniazid, levoflox, pyrazinamide, and methambutol. This was done mainly for two reasons. One was to prevent drug interactions. Another one was to prevent any further worsening of thrombocytopenia because rifampicin can be associated with cytopenias, especially with ITP. So the patient did not have any hemorrhagic manifestations as such. So prophylactic RDP transfusions were done only when the platelet count dropped to less than 10,000. He received one dose of romiplostim 250 micrograms subcut. One dose was given. A short course of oral prednisolone also was given, and he was planned for a rapid taper on OPD basis after platelet recovery. The platelet count at discharge was 35,000, and drug resistance could not be sent in view of both non-availability as well as financial constraints. We repeated a platelet count at 2 weeks during his OPD follow-up, which had improved to 40,000, and his repeat HIV-2 viral load after 2 weeks of the new regimen, abacavir lamivudine with double dose dolutegravir with darunavir-ritonavir, showed undetectable HIV-2 viral loads. So this patient's final diagnosis was PL-HIV-2 with an ART failure, type 2 diabetes, disseminated tuberculosis with pleural and multi-level spondylodiscitis, oral candidiasis, HIV-2 related cytopenia, and tenofovir-induced renal tubular acidosis. So going on to the discussion. Shall I carry on, sir?
I think you carry on. Then probably end of it will take the questions. Yeah, fair enough. Make it fast.
So we looked at all the possible causes of HIV, all the case reports of HIV-associated cytopenias, and we came across several case reports as well as review articles which looked at HIV causing ITP as well as causing cytopenias. So HIV can cause cytopenias by several techniques. One is it can cause an opportunistic infection which can cause marrow infiltration, but HIV in itself can also involve the marrow and cause cytopenias. We also looked at rifampicin-induced cytopenias, and there are several case reports as well as review articles which has looked at this, which I have summarized in this slide. So how exactly to manage integrase failure? So the most common mutations that we come across following introduction of an integrase inhibitor is G118R, R263K, Q148H, RK, or N155H. So the best option is actually to create a regimen based on the genotypic resistance testing, but this could not be done for our patient because of one of the non-availability because he was HIV-2 infection, and second because of financial constraints. So for our patient, we started him on abacavir lamivudine with double dose dolutegravir with darunavir ritonavir based regimen. But there are other options of we could try it because of the toxicity of this regimen and because of the pill load. Other option is we could have tried for dolutegravir with darunavir ritonavir based regimen based on this rescue trial. So the take-home message is workup for all causes of cytopenias in a PL-HIV patient, and HIV itself can cause cytopenias. Also to look out for drug-induced cytopenias. In case of integrase failure, change your double-dose dolutegravir with darunavir ritonavir based regimen, and whenever possible, get drug resistance testing prior to change in the regimen, and always check for drug interactions. Thank you.
Sorry for comment. Shall I comment, sir?
Yeah, you can go ahead. Go ahead.
Why 4 drug, I think, dolutegravir, BD, darunavir, ritonavir, I think, abacavir, lamivudine. Still,
So
I have this patient virally suppressed. Why need for this much?
he was not virally suppressed. So when he had
Not
come with
virally
his
suppressed.
fever with
Not
cytopenias,
virally
his
Okay.
HIV-2 viral load was 63,000. So he was failing on abacavir, lamivudine, dolutegravir based regimen. That is why we changed the regimen to this. This is what NACO recommends as the third line regimen for patients who are failing second line regimen.
I
I
think
don't think.
Dr.
Sorry, sir.
Parth, you want to add anything or?
No, sir.
I think Anjali, I agree with Satnam that why to go for 4 drugs? You could have gone for only darunavir based therapy because we are just practicing. Many patients who are failed on dolutegravir, we are changing to darunavir, ritonavir, and they are doing very well. No need of giving 4 drugs. Secondly, about the dual therapy, DTG, darunavir, this patient is not eligible for 2 drugs. Any patient you want to switch on 2 drugs, the first thing, the patient adherence has to be very good. He should not, and his virus load has to be undetectable minimum for 6 months to 1 year. So the 2 drug combination is not a good suggestion in this patient unless until patient can't afford or are some constraint, then you can go ahead. But I would have started even this patient on bictegravir. When the patient they will fail on dolutegravir, there are certain patients still bictegravir is useful. So I would have started on bictegravir because there was this you are giving levofloxacin, not giving the rifampicin. So I would have gone for bictegravir.
But we don't know his resistance testing we could
And
not get, and he's
No,
been on
but
dolutegravir based
this is my
regimen. So
experience for last 7 years. I'm telling the ground realities.
Can I interrupt, sir? This is Dr. Praveen.
Yeah.
So basically, patient failed on abacavir, lamivudine, and dolutegravir. So we think it is an integrase failure, considering that the patient is compliant to the treatment. So at that situation, we expect that patient will have M184V, which will cause lamivudine resistance, which will again cause a partial resistance to abacavir, and K65R also is expected. And patient also has an integrase resistance. So in such situation, if we just switch from abacavir lamivudine to dolutegravir to abacavir lamivudine darunavir ritonavir, it will be monotherapy of darunavir ritonavir. Because darunavir has a very high resistance barrier, probably patients viral node will not come up for the next 2-3 years. But at this point of time, I don't think a functional monotherapy regimen is right. So abacavir lamivudine dolutegravir BD with darunavir ritonavir is a right regimen, which we can argue that probably we can remove the abacavir and lamivudine and continue just with dolutegravir and darunavir ritonavir. Now that
Yes, sir.
there is some evidence, so that is one thing which we could have done, giving dolutegravir with darunavir ritonavir. But this patient is under a NACO, so right now NACO recommends to continue with the baseline NRTA regimen. And the idea of giving a baseline NRTA regimen is that the mutations maintains decreases the viral fitness. So that could be helpful. That is the idea. But this is what NACO recommends at this point of time. Agree that dolutegravir with darunavir ritonavir might be a good enough regimen. But right now, this is what NACO recommends.
No, but
And there is
no two drug combination should not be given in this patient.
no two
They're
drug
not
sir.
viral.
This is
Yeah.
two drug regimens. This is
These are
not a
not
case for two drug regimen at all.
Yeah, I would have
active.
switched over to darunavir, but as you said, the NACO guideline is the government, then you have to follow the NACO guideline.
Yeah, and I don't think there is any clinical advantage of switching dolutegravir to bictegravir, sir. Even though there are some mutations where the bictegravir has shown to be
Yeah,
little
yes,
bit
yeah.
more
No,
tougher molecule, but that is not
no,
clinically actually
no,
significant.
here, Dr. Santnam, na?
Yes, sir.
Yeah.
That's
There
Praveen,
are
sir.
two,
Praveen.
no, there are too many tablets. Bictegravir, you are going to give only one tablet. If dolutegravir fails, we are switching over to bictegravir. I'm practicing for last 7 years, and they are doing very well.
Yes.
So just want to tell
So
that
I'm
this
sharing
in
my
this case it is
experience. Because for each and everything, if you go for the clinical trials, you only practice the clinical trials, nothing else, not the ground realities.
No, sir. So basically, because the integrase inhibitors are very tough molecules, even with the monotherapy trials are there where patients will not fail for the next 2-3 years. That doesn't
Yeah,
mean that
but
patients
this patient has
won't fail
failed
in the
on
fourth
3
year.
drugs. This patient has failed on 3 drugs.
Yeah, so you cannot switch it to bictegravir. That's what I'm trying to
No,
say.
I mean
So if you take it,
bictegravir, tenofovir, and FTC, not only
sir,
bictegravir.
yeah, I agree, sir. But tenofovir FTC patient is already resistant to, so
No,
that will
what
be
resistant
bictegravir
to what?
monotherapy.
No,
Tenofovir and
lamivudine, you have to give it with resistance or no resistance, correct?
yeah,
Abacavir is the weakest drug.
yeah,
Yeah, so
and
the TAP
dolutegravir
is,
patient
so
failed on.
TAP, Abacavir failed, TAP works.
No, sir, it
Yeah,
won't work.
it works, definitely.
The patient with integrase failure,
Praveen,
you cannot switch from dolutegravir to bictegravir. I understand. I
Yeah.
risk making.
Sorry for interference. So there, Praveen sir, what sir telling
Anyway,
instead
it's
of
a
abacavir,
good
we'll switch to
argument. Yeah. Okay.
instead of
So
abacavir, sir want to tell
we
tenofovir.
no.
That's
So
all.
the whole argument of switching abacavir with tenofovir is a
Uh,
very old concept when we used to use NNRTS. So once we started using integrase inhibitors, there is no comparison of tenofovir is better than abacavir. That won't hold good because the integrase inhibitors are so strong drugs. So that comparison of abacavir with tenofovir doesn't hold good when the background regimen is
No, but you
integrase.
need a multiple drug here. No, only one drug is not enough.
That's what I'm
Praveen,
saying, sir. That's why- fine, fair enough, sir. Yeah.
Anyway, we'll go ahead. Yeah, we'll go for the
and the
next
next
presentation
person
now. Yeah.
we have 2 more cases because this case is a little bit complicated case, and remember is HIV 2 and he was not virally suppressed, so there were a lot of combinations which could have tried. So, but this case highlights the complexity even now in 2025.
sorry, sir. I think
Uh,
your slides are not visible. I think for me only
no,
or not.
who is presenting? Parth is presenting next, right? Or
Yes, sir. Yes, sir.
yeah, upload. Meanwhile, we'll just summarize the older case. So the older case represents the complexity of one is HIV 2, how availability of the viral load. Second thing is on treatment failures are occur. At that time, it's important for us to understand drug interactions and drug compliance, drug absorption levels. So all three are important. So, and in this patient, when somebody has a disseminated tuberculosis on virally unsuppressed, idea is to suppress the viral load at the earliest. Baseline, we can all, I mean, later on, we can always change over to 2 drug. At that moment, idea is to suppress it so that patient won't end up with other opportunistic infection. Anyway, we'll move on to the next case, Parth. Can you make it brief, Parth?
Yes, sir.
Uh,
Sure. My slides are very
So
brief.
should I upload it, Raj sir, or you
Yes,
want
sir.
to upload?
No, you can
Should I do?
upload.
Okay, fine.
Yeah, please.
Just give me a second, sir.
And you can change the slides also as I tell you.
Yeah, I'll do that, sir. I'll do
Thank you.
that. Is it visible, sir?
This, I
I'll
think this
just scroll it to the presentation.
right from here. Yeah.
So, sir, sorry.
Yeah.
Yeah.
Yeah, you can start with the next slide. You can begin with the case.
Fine.
The next slide, sir.
Yes, sir.
So my case is a 55 years old male. He's a school teacher from US, currently staying in India since last many years. He's unmarried and stays alone. He came with a history.
Sorry.
Yeah, he came with complaints of dry cough since around 2 months, for which he was seeing a chest physician. He was taking inhalers and watery diarrhea since 3 days and fever since around 3 4 days. So with this history, um, he was admitted at a local hospital where they noticed that he had hypotension. So was shifted to a higher center where we saw him. On detailed history, he told that he has this symptoms of weight loss since around 2 months, around 220 kgs. Next slide. Next slide. Sir. Yeah. So when you so previous slide, yeah. So when we were examining him, his heart rate was 105, BP was 80 by 50. He was not responding to IV fluids, and he was kept on inotropic support. His saturation was just 90, and he looked little dull, pale, very much emaciated, of course dehydrated, and there were small lymph nodes in his neck and axilla. He had oral thrush and just showed few crepitations. Maybe he was so drowsy because of loose motion, hyponatremia. He had aspirated probably. So because he had a lot of gurgling sounds also. Per abdomen, he had a soft splenomegaly. Next slide. So this is his X-ray and the blood investigation which showed there was bicytopenia. HB was 8, platelets were 69,000, retic count was 1, and IPF was 8. With this further evaluation showed his creatinine was normal, LDH was borderline, ferritin was very high, and SGOT was slightly elevated with normal other markers. PCT was 4.5 with a cortisol of 32, which is normal. So next slide. And since he had such a vague syndrome with very bad clinical presentation and not responding to inotrope with oral thrush, we sent his HIV and it was detected to have HIV1 with viral load was around 20 million copies. His absolute CD4 count was 32, which was 5%, which was suggestive of marked T cell separation, T helper cell separation. His stool routine was showing just two pus cells, where no RBCs, no cysts, no was, no eggs, and stool for modified AB stain was negative. He was admitted under a physician who started him on cefosalbectam and nitazoxanide with supportive treatment. So next slide. So I just so next slide. Hello. So what could be the possibility that such a bad CD4 count and high presenting with loose motions? We have already discussed that there are lot many of DDs, but since his stool routine was normal, there was no oasis, and I think we have done his stool biofire also, which was negative for all the OIs, which detects in the biofire, and he was on nizonide and antibiotic coverage. So next slide. So on day 2, his HB dropped, his platelet dropped, and loose motions were getting better, but fever spikes started to increase. His hypotension was just not getting recovered. His inotrope went from 1 to dual to full doses. He developed peripheral cyanosis. He started having some cyanosis in the periphery because of maybe inotropics, high dose, and he was getting edematous because of too much of fluid overload. The albumin was normal, and day 3, his counts further dropped to HB6. He was not having melena. We checked for stool OB, which was negative. HB was 6, WBC count was 4,000, platelet was 20,000. Antibiotics were upgraded to meropenem, teicoplanin, and aniglapangin. And on day 5, his platelet dropped to 14,000. Now, at this point of time, when we started to get his reports for all OIs, which was coming negative, his crack was negative. Sir, are you able to see my slide?
Yeah, we can see. Go ahead. I can see it. Go ahead, Parth.
Yes, sir. So his viral load was negative. CMV viral load was negative. His urine histoplasma antigen was negative. His BD glucan was negative. His blood stool culture was having no growth at day 5 also. And he was requiring multiple transfusion to maintain his hemoglobin. And day 6, his platelet dropped to 13,000 with the fever spikes were persistent. So with this, we further wanted to evaluate why he has such a high grade fever spike and any other OI which are not getting picked up on this routine evaluation. So we did a PET scan. So next slide. Yeah. So PET scan was showing the same lymph nodes as we have seen in the previous cases also. And nothing apart from that, just uptake in the lymph nodes and the bone marrow. And finally, since we didn't get the answer, he underwent a bone marrow, similar like a previous case, and bone marrow and lymph node biopsy was done. So next slide. Yeah. So fever spikes was persistent. He went into acidosis, worsening of inotropic support, requiring multi-organ failure supportive treatment in the form of SLED for correction of acidosis. His provisional report from the bone marrow aspirate showed paucicellular bone marrow with increased macrophage with evidence of hemophagocytosis. With this, we thought of this is HLH maybe triggered related fever. So he was started on dexamethasone, IVIGG for HLH. So next slide. And meanwhile, his lymph node biopsy report also came, which initially showed reactive lymph node with follicular regression. But after few hours, the pathologist called us. He told us that he did his IHC, and which was showing a lot of inclusion bodies on HHP8 with a large number of plasmablastic cells. And his interleukins levels were very high. So patient was worsening on hemodynamics, finally went into multi-organ failure. And with this picture with high HHV8 and plasmablastic reactivation suggestive of Castleman's disease, we gave him first dose of anakinra. He was already on, 1 second, sorry. Yeah. So finally, he required multi-organ support and he went into failure. Yeah. Yeah. So he received first dose of anakinra on Dexa and IVIGG. So next slide. So next slide. Hello. Hello.
Which slide you wanted to on the
Yeah. So this is a histopath which showed the I think the picture is not little clear, but the D picture, the fourth picture shows lot of CMV, not sorry, HHV8 IHC. So next slide, sir.
So this one, we can see it
So next
clearly,
slide,
sir.
the histopath. Acha, I am not able to see. Okay.
We can see
So
it
this
clearly, sir.
D, the fourth picture, yes sir, the D, which showed inclusion bodies of HHV8 on IHC, and another part was just lot of plasma cells, abundant of plasma cells suggestive of Castleman's. Sir, can I see the next slide? So next slide, please.
Sir, it's getting lag. Just hold on, sir. I am on the right slide, sir. It's Castleman disease.
Yeah. Sir, I'm unable to see the next slide. Yeah.
It's
So finally, hello.
it's a Castleman disease slide, sir.
Yeah. So as we are all aware of, just a small discussion on Castleman's disease, which is a lymphoproliferative disorder, and typically seen in HIV-associated patients with HHV8. It is very close to this co-infection, and which has high morbidities and complication, which can be avoided by early diagnosis and treatment. So next slide. Although we did everything for this patient, I think the slides are slow. Yeah. And as we know that it is there are two types of Castleman's. One is unicentric, one is multicentric. Unicentric in like it's a focal involvement, and multicentric is like diffuse in this case. We can see the PET scan pulled off lymph nodes, and because so much of B cells are activated, they release so much of cytokines. There is hypercytokinemia, which releases and causes endothelial dysfunction. And since it is associated with HHV8, with such a bad immunological set in this patient, like CD4 was less than 50, with high interleukin level. His interleukin level was 86, which normally is less than 25, almost 3-4 times. So next slide.
Sir, here it is changing
And like this
instantly,
case,
I guess. Yeah. Sir, here it is changing instantly. I guess some network issue, sir. So it is featuring,
right.
yeah.
Right. Just the same thing which has like Castleman's with multicentric with hypercytokinemia. Predominantly interleukin 6 is in a surge and releasing so much of cytokines, destroys the endothelium, and there is a fulminant hypotension. So next slide. Yeah. And epidemiologically, majority of 80% of patients who has this type of disorder where HHV8 is associated with Castleman's are HIV patients, and predominantly seen in male patients
Light
with
changing
a
slow,
very
or is
low
it
viral load or undetectable viral load. This was something strange with a CD4 count of around 150 to 300, and the lymph node predominantly involves in axillary, abdominal, and pelvic, mediastinal, and cervical, with a hepatosplenic and some amount of bone marrow involvement is there. So next slide. The clinical picture includes fatigue, weight loss, myalgia in early stage, but as the disease advances, there is diffuse lymphadenopathy with hepatosplenomegaly, and finally, when the stage comes where there is a lot of cytokine release, they goes into hemolytic anemia, gastrointestinal symptoms, and HLH, as we can see in this patient. So next slide. And since it is difficult to diagnose just on basis of lab evaluation, we need a syndromic approach, which shows that lymph node should have HHV8 inclusion bodies with immunohistochemistry showing HHV8 and lymphoproliferation. Minor criteria includes all the elevated cytokines with anemia, thrombocytopenia, and high ferritin, high interleukin 6, with some amount of hepatic renal dysfunction and polyclonal hypergammaglobulinemia. So next slide. And patient do have some type B symptoms, of course, maybe because of HIV, but
Finish.
predominantly because of so much of interleukins. So next slide, sir.
Okay, try to finish it off fast.
Yes, sir. So last slide, sir. So treatment includes if it is a unicentric, then complete excision of the lymph node is enough for the treatment. But if it is a multicentric disease, then we need um, higher immunosuppression in the form of firstly we go with steroids, but they do require higher interleukin 6 inhibitor, which include tocilizumab, cetuximab, and maybe like anakinra and TNF alpha inhibitors are also required, like bortezomib, and some amount of time they go with thalidomide also. So next slide. Since the virus itself is the issue, HHV8, which cannot be getting like there is no viral inhibitor for HHV8. The prognosis is bad for multicentric, but unicentric they do very well. And HHV8 associated Castleman's has a lot of flares in between, and they are at a higher risk of getting NHL. Maybe that may be the reason why HIV patients are going into NHL predominantly rather than any other malignancies. So next slide. And finally, with all this patient's report, the bone marrow report came negative for TB, fungal and bacterial cultures were negative. But patient unfortunately succumbed to his illness and had a cardiac arrest. And finally, he died because of HLH, because of HHV8 induced multicentric Castleman's disease. He was recently diagnosed with HIV-1 infection. I think this was the last slide.
Yeah, excellent case, Parth. Really complicated. I mean, I'm happy that you could make a diagnosis. It's important because majority of the time, what we end up doing is any fever in HIV patients, we end up starting ATT. But sometimes patients like this do come to us. It's important that you make a diagnosis because the next patient we can save. Because if you look at it, this patient definitely had a lot of odd signs which are not suggestive of tuberculosis. Of course,
Yes, sir.
you had resources to investigate further, right?
Yes.
So
Yes, sir.
classic, and now it all depends on which setup you work.
Correct.
So if the fever is continuing and patient you start ATT, the two challenges what we find. One is if the LFT is abnormal and you are always trying to give a non-hepatotoxic ATT, right, which often complicates the issue,
Right.
right? So this case again reiterates systematic evaluation and reaching to the diagnosis. It's an extremely rare case. I would have seen one or two, that's all, right? But it is important. The other important thing is, if I ask from a clinical standpoint of view, what else you could have done a little bit faster to give rituximab along with daunorubicin or something, which could have saved the patient? How long did this patient was there? About 8 days, is it?
Yes, sir.
Okay, right, fine. So, I mean, it's extremely rare. I would have not thought of that as my first differential diagnosis. Only worry in these patients is whether it is an NHL, right? Or some of the NK cell lymphomas do very badly, which typically present in the nose and lymph node like that. They tend to have very bad prognosis, even with effective chemotherapy, right? So this patient, of course, I can make out that he could afford it, and then you could make a diagnosis, right?
Right,
Have you
sir.
started ART on this patient?
So we couldn't, sir. We just wanted to evaluate for his underlying fever before we could have really gone into ART.
Multicentric Castleman's actually prognosis is quite bad. And
Yeah.
other important lesson for all the audience in this case is just because you find hemophagocytosis in the bone marrow doesn't mean it's always HLH. Most important in HLH is what is driving HLH is very important because once you give HLH regimen, it will knock off every immune pathway, right? Either
Right, sir.
what Kenra you used here, we use etoposide here with steroids, then we will never know what is driving it. So probably in this case, the HHV8 induced multicentric Castleman disease was driving the HLH, right? And this
Right,
is
sir.
known in HIV patients. Yeah, that adds to the complexity. Moment you give immunosuppressive drugs, the fever will come down, all the inflammation settles down, the liver starts becoming better, platelets. Because irrespective what of the cause, you're just knocking off all the pathways, right? So again, it
Right, sir.
reiterates you do a proper lymph node biopsy. And traditionally, what we are taught in medicine is you do one after the other. In a sick patients, it doesn't work like that. You do it everything parallelly, right? You start treatment, go for biopsy, get your pathologist on the board, right? Because they don't give you much time like this patient. Our patient one, whatever I've seen, I've lost him because he came late to our hospital actually, almost for 2, 3 weeks. So the other important thing in this case is what is your take on when ART should have been started in this patient? Just imagine this patient was sort of started on treatment. What is your take on starting ART?
So almost we ruled out all the OIs, and PET scan was just showing the lymphadenopathy. If we would have crossed this phase, he would on be on ART very early, like
Yeah,
maybe next week. Like
traditionally the issue was when patient has cryptococcus or TB, you always delay it. These are the two standard indications where ART you generally don't start it very early, right? But in some other conditions like this is also very risky. Because again, I said what is driving all this is important because there's a flare up of HHV8 and I'm sure the viral load would have been very high. All these are driving factors. So sometimes we just flow algorithm from the national guidelines, we might get into trouble. But again, these are exceptions than rule. 9 out of 10 times what is written in our national guidelines do work. But these complex cases, when they end up with us, we should be very careful, right? Very interesting case. Did you publish this or not?
Not yet, sir.
You should publish it. Full case. It's very rare, but would we lost the patient, but it's a good case.
Thank
We'll
you,
go
sir.
on to the case because it's almost 9.
Yeah, Dr.
Sir,
Park.
yeah.
Yeah.
Yes,
Yes,
Saple
sir.
sir has comment, sir, because his mic was mute. Dr. Verma, if you can. Yes, sir.
Yeah, first thing, Park, this is thank you very much for the rare case. Hardly we see this type of cases in the practice. In
Right,
my
sir.
last 30 years, I have not seen this. Probably I may have missed it also. Was there any skin manifestation in this patient?
No, sir. We examined it thoroughly, but just lymphadenopathy, nothing else.
No,
Because of
any skin.
hypotension, he
Because
was having a lot of mottling, sir.
yeah,
He was
usually paraneoplastic syndrome, the Castleman's tumor is associated with paraneoplastic syndrome, where sometimes they get a skin manifestation. And if you do a biopsy from skin manifestation, it shows three things together. You'll find in the same histopathology lichen planus, you'll find intermediate lymphocytic infiltration, and even the acantholytic cells suggestive of pemphigus. That is many times is a diagnostic. Secondly, the Chandigarh AIMS, they have developed immunoblot recently that is very diagnostic. This is the histopathology skin I'm showing, where you get intermediate, of course the slide is not good, but lichenoid changes, then you get erythema multiforme like changes and the pemphigus like, all three together. So if there is any skin things, always you look for that biopsy. Secondly, immunoblot. Now they have developed this test immunoblot to diagnose Castleman tumors. So I think we can take a help when you're suspected. Next time you can talk to AIM Chandigarh. Then coming back to, see, they have shown on the slide of the opportunistic infection, the chart opportunistic infection. Any patient where CD4 count is very low, usually nowadays you are seeing there multiple opportunistic infection. So you have to look for the multiple opportunistic infection. Secondly, of course, lymph nodes, they are necrotic. First, you think of tuberculosis, and you go for the bone marrow. When we do bone marrow, we do acid pass, that is AB, pass staining, gram staining, and look for the malignancy. These are the four things always you should look for it. And in any CD4 count, always keep in mind tuberculosis. Okay. So we'll go for the time is permitting in 9 o'clock. I
Sir,
think we
to
can
the
stop
eminent
it. Yeah.
speakers,
Thank
there
you.
is 10 minutes there. If you can squeeze in Dr. Shantanam case as well.
Can you
If the
I think Dr. Santanam, you present only one case, huh?
Yes, sir. Yes, sir.
Yes, okay.
I'll put it, sir. So this
Yeah,
is so we have Dr. N. Shantanam, who is a DM infectious disease fellowship in from RSTM student, who is a consultant in Vellamal Medical College, Madurai, and specializes in diagnosing as well as treating adult and pediatric infection. With this, I introduce his case of weight management in HIV. Sir, over to you. I'll change the slides for you.
Yes, sir. No problem. I will share, sir. No problem. No issue.
Yeah.
I will do it. Just a second.
So should I unshare this thing? Or you?
Yes, sir. Better use unshare it.
Okay.
Better. Okay.
Thanks to the entire panelists for extending by another 10-15 minutes.
I think my
Thanks
screen
to
is
the
visible,
delegates.
sir.
Yeah. Yes, sir. Yeah, visible. Visible, sir.
Okay, one minute. Just. Okay, fine. Sorry. I think it's coming. This is case-based scenario. I don't know how. My voice is okay,
I
sir?
think 1 second, huh? Gajendra,
Yes, sir.
who is the moderator, who is panelist? I'm confused. I do not know what
No,
is
no, sir.
going on.
You are the mod. I am just saying, sir, for the time thing. So I was just requesting on that. Of course, sir, you are moderator and Dr. Verma is taking care of the as a
What is the
panelist, sir.
function of the panelist? He is
Yes, yes,
supposed
sir.
to answer
Yes, sir.
question, no?
Yes,
He's
sir.
not supposed to conduct the meeting, no? who is supposed to conduct
Right. Sir,
and follow the rules of the meeting, no? Okay, Santanam, go ahead with your presentation.
Yes, sir. Good evening to all. This was a case, 48-year-old woman, known case of HIV, obesity and hypertension. She is on past 2 years on pictogravit, TAP and FTC. Now virally suppressed. Now the problem is she is weight gain, repeatedly weight gain. Problem the like exercise is not done. That even BP also is going high. The BMI last BMI it will be 39. Now coming to you, they asking about regarding weight. What will do? You want change some other regimen or you want to continue? If you want change regimen means what regimen you want change? Anything newer drug like captogravir, elpivarin or dolutegravir based therapy or doravirine or darunavir or what drug you want change? Anyone comment, sir?
Yeah, let other people, panelists and the other speaker can want to say anything. Anybody want to say? Okay, Santami, go ahead. What
Sir.
you would like to continue? Yeah.
Yeah, definitely, sir. The answer also the continue only, sir. There will be continue same regimen. There will be no studies favoring for
Oh,
changing
why
regimen.
you continue same regimen? Because
For
bictegravir is well known for weight gain, no?
oh, accepted, sir. The problem is what that that one I want to tell, sir. There will be no RCTs favoring for weight because of the patients complaining of weight gain. You want to change the regimen. That's what they telling here. Whatever regimen I'm given, but exception the few studies what I'm going to discuss. If you want
Okay.
switch over to Insti to Darwin based regimen, there will be no reverse in weight gain. Suppose you want to change, there will be TDF to tab. Sorry, it's tab to TDF. I told wrongly.
Yeah.
Finally, tab to TDF. You want to change. TDF means there will be possibility of many studies. There will be small weight loss, but other regimen there is not favoring according to this study. Another thing, if you want to switch over to Doravirine based therapy, there will be this study shows zero point 0.8 kg per year. Only the loss. Weight loss will be only minimum 0.8 kg per year. Another study is also there. There will be few favoring with this trial or this RCT shows that somewhat weight reduction is there. Doravirine based therapy, even some other regimen also. This is not much more significant even though evidence based. Again, what I'm going to tell means if you want to tap to TDF means there will be somewhat better. Even pre-exposure prophylaxis, somewhat patients want to continue, there will be TDF dose such much more better response compared to captogravir based regimen. Same case, I'm continuing with that. You are continuing pictogravir based therapy. Again, the attender asking about after you are explaining about diet and exercise everything, but again they asking about I want to go pharmacological regimen, whether I will go semaglutide or
Yeah.
desertib.
One sec, Santanam.
Yes, sir.
See, when this type of patient with the bictegravir, they come with the weight gain. The first thing we ask them about their exercise.
Exactly, sir.
And out of 150% will say there is a lack of exercise, there is some change, and the diet.
Yes,
These
sir.
are the two things we have found almost in 50%, and then we continue in 50%. After finding out, we ask them to about the diet control and exercise. Now you go ahead. Yeah.
No, same patient asking about shall I go for pharmacological regimen? If at all want, mean what regimen you want to go? Semaglutide or terbinafine? Or both will be equal? That's what she is asking to you. What will do? Sir, any comment, sir?
Yeah. Well, as I said, the first 2 months, we ask the patient about the exercise and the diet control. After 2 months, when they come and still they are putting on the weight out of proportion, then we can go ahead for this. But that is the second choice, not the first option.
Exactly, sir.
So,
What
yeah.
drug you will prefer?
Pardon?
What drug you will prefer, semaglutide or terzepatide?
See, yeah, usually tirzepatide we prefer here in our clinic. Yeah, but that is the second option, not the first option. Okay, so what you did?
The same thing only, sir. Whatever you told, same thing only. Terzepatide will be better thing compared to comparatively. But there will be studies shows there will be weight loss. It will be equal both terzepatide and semaglutide. The tolerability will be terzepatide. It will be better. The problem is cost only. Semaglutide there will be side effect much more compared to terzepatide. There will be
Cheaper.
there.
Okay, yeah.
Other drugs are what are there? There will be different drugs there. Orlistat and pentyramine and naltrexone and pipropion, even liraglutide, there will be GLP, GIP. Semaglutide and liraglutide, there will be GLP-1. Tirzepatide, there will be GIP, GLP agonist. There will be different drugs are available. There will be tirzepatide and semaglutide you are going there. Where will be contraindication is there? Tirzepatide, there will be medullary carcinoma of thyroid and history of pancreatitis. The conditions will be contraindication.
Yeah.
Other things are much more same only. The patient
Yeah.
same thing you are telling like now the problem you started semaglutide. Now patients is started with semaglutide. The why started means there will be weight loss. Same time CAD patients there will be semaglutide comparatively better. Now she is complaining of nausea and vomiting. Nausea vomiting. Why means there will be you increase the dose. Now compared to 2.4, I think there will be say increased another 1.7 mg you are increased to these patients. Now complaining of persistent vomiting. The common side effect is semaglutide. She is getting like non-bilious, non-bloody after meals. Now asking to you, in addition to anti-emetic, what will do? You want what anything you want to do? You want to discontinue semaglutide or you want to,
I want to know what you did.
sir?
What you did.
What I did,
We want the
sir.
ground realities, no? What is your experience?
The same thing only. What I want, there will be, don't stop semaglutide.
No,
Don't
did you
stop.
reduce the dose? You reduce the
Yes, sir. I reduced the
frequency?
dose from
Yeah.
1.7 to 1 mg.
Mhm.
I encourage the same answer I given, sir. There will be, you would be small amount of frequency. You increase the frequency, amount of meals will be reduced.
Okay, and patient could tolerate.
Yes, sir. You reduce the tablet also. Two things I did, sir. Another thing, semaglutide dose reduced. Another thing is meals amount also reduced. The frequency will be increased. There will be, you want to continue
No, yeah, but
terzepatide?
any drug interaction with the antiretroviral, anything with that.
Nothing is there. The terzepatide, both semaglutide, there will be
So
nothing.
we can give along with the antiretroviral, correct?
Yes, sir, exactly.
And how long you have given for 3 months, 6 months?
Yeah, that one I will come back.
Yeah.
uh, Definitely, there will be, you give that same time, there will be, I will give the answer, sir. Don't worry. This common side effect to semaglutide, nausea, vomiting. Even terzepatide also nausea, vomiting is there. Other problem is diarrhea. Constipation, there will be, I am not sure, but data is telling. This was only same thing again coming. Now same patients coming to you. The He lost 10 kg weight loss because of the during that time you are from 1 mg to 2.4 mg slowly you increase the dose. Same time there will be meals amount decreased. Same time anti-emetic also they taken. Now they asking about 2.4 mg. It's okay. You reduce to insulin 1 mg. Again you again increasing slowly. Now on 2.4 mg. Shall I continue or not? This will be little bit dose based therapy. What I want to tell means there will be different dose aspects. You need to know. There will be
But
equivalence. Say,
Santanam, you continue with the anti-emetic along with the.
yes, sir. Because of the I increase the dose. That's why I
Okay,
continued with
and
that.
how long your anti-emetic was given? Before or after?
This one TDS given, sir. This
Yeah,
one
but
given
how
for
long? You started before giving injection?
30, 34 weeks. These patients given, sir.
Okay, and we
Hmm.
continue all the time?
Yes, sir. This one
Okay, and
started
then you
after our
increase the
method.
dose, and then you increase the dose, and there was hardly any untoward effects, correct?
Yes, sir.
Yeah, that's
Exactly
good.
that.
Very good. Yeah.
Same like steroid, there will be prednisone, methylprednisone, there will be equivalent dose, semaglutide, tesabotate, that will be variability is there. Semaglutide 0.5 mg equal to tesabotate 2.5 mg.
Mhm.
This was different dose aspects.
Yes. Okay.
That only you need to know how equivalent. Suppose you want to change tesabotate, means that only you need to know. The
Okay.
same thing only we given. The problem during the time there will be patients not able to afford. After that we discontinued. But problem again, there will be patients again gain weight. The other problem, there will be
Oh no,
sarcopenia.
you mean they gain weight after stopping,
Yes,
correct?
sir. Yes, sir.
Yeah. Okay. Okay. Yeah.
Even there will be sugar also uncontrolled. This one's FDA approved indication for GLP and GAP, GLP, GAP. There will be even obesity with the diabetes and CVD risk and OSA risk and mass risk,
Mhm.
sir.
Okay. Okay.
Mass area, I'm not going much more inside.
Okay.
This one's the next small case I want to tell. Again, sorry, 54-year old female, Maria. She's taking 18 years on HIV. She's on pictagravir-based therapy. Now viral undetectable. CD4 is 640. Now coming up hypertension, hyperlipidemia, and BMI is higher side. BP also higher side. She's on valsartan, and your cholesterol is higher side. Previously smoker. Now coming to you. Sorry, sir. Sorry. Sorry, 1 minute.
Gajendra, help him.
Sorry, sir. Sorry, I'm coming back.
Yeah.
There will be coming to you. Sees now you want sees you are taking ACVD score risk. It will be 5.2. You are have app nowadays. There will be you coming like you want to add statin means which statin you want to add. Otherwise, you want to continue semaglutide or tesabotate alone. That's what questions coming.
Yeah. Yeah. Go ahead. 1 second. I'll join.
There will be obviously you will start with the statin, any statin you want. Better you will go for pitavastatin. It will be comfortable. You will feel there will be even rapid trial. It will be favoring for pitavastatin. There will be few indication is there. Few indication is there. Sorry, I think some disturbance is coming. You will be 40 to 75 years with lipid level. Sorry, 40 to 75 years, more than 40 years, you need to consider statin. Other thing is AACVD score risk more than 5%, you need to consider. Preferred statin is pitavastatin. If you are going to check for HIV patient diabetes, always go for fasting level. Don't go for postprandial level. This much only I want to tell. Thank you, sir.
Okay. Thank you, Satnam. Yeah.
Small presentation, sir. Mine.
I think anybody has got any suggestions or any concluding remarks? Dr. Verma ji? Dr. Verma is around? Yeah. Dr. Anjali?
Nothing, sir. Just excellent case discussions. I learned a lot from today's presentations. Thank you so much, sir.
Anyway, but now you are practicing, you are treating patients. So what is your message for the World AIDS Day?
Just work up properly for opportunistic infections, roll out OIs before starting ART. And NACO as such covers TLD at free of cost. So as far as possible, especially with financial constraints, to refer to NACO for ART initiation.
Yeah, I entirely agree with you. Any patient come to, of course, now we are retired from the government. When any patient comes to a private clinic in a counseling, one of the statement is there from the beginning of the counseling. The ART is available free in all government hospitals. So that is the information we have to give there. It's a very good message. Dr. Parth? Dr. Parth?
Sir, I think he got disconnected. It seems he was already facing network issue. So it seems
Okay.
yeah.
Dr. Verma-ji?
Yes, sir.
Yeah, but what is your message for AIDS World Day?
I think it's important that we spread awareness, because along the last 30, 40 years, I think we lost that momentum. People, I think, are still thinking that it is not a major problem now. I think we lost that momentum of creating awareness. Early screening is the only way, or probably one of the important steps to prevent the spread of AIDS, because in our state, we do have a lot of cases. And of course, early recognition now with very well-knitted network of ART centers, I think treatment can be easily manageable. I think the screening is very important and we pick up cases early. I think that should be the message.
I entirely agree with Dr. Verma-ji, because early detection is the only key for the prevention of any complications, any sequelae and epidemics. We can only control or keep under control only early detection. Unfortunately, I'm a dermatovenerologist. I'm telling all my colleagues, because the earliest detection will done at the STD clinics, sexually transmitted diseases, then dermatologists, but they are not taking it. Probably, as you said, they have forgotten or they have developed complacency, but they have to think seriously and they must check up HIV each and every case. That's a very good suggestion, Dr. Verma-ji. Now, Sadnam? Santnam?
Sir, nothing, sir, nothing.
No, you have to give some suggestion, because you are in the field, no, you are practicing HIV. So you have to give some suggestion, whatever you feel.
The problem still, I'm feeling like in my practice, in my place, social stigma only the still problem I'm
So
feeling.
that's very important, no? Very important, no?
Yes, sir.
That's what one of the finding of the World's Congress. Stigma is still persisting. We are not able to minimize stigma. Stigma is a very important, because patient, still few patients, they come with a very late stage because
Yes,
of
sir.
stigma. They don't want to tell anybody, even they don't take people in consideration. So that is also very good, because as Dr. Verma says, now there is a complacency. Almost you are forgetting there is a HIV, and the fresh awareness is required. Otherwise, may land up again with the square one. I think thank you all. Thank you. Gajendra, thank you, your team and Hetero Healthcare. Okay.
Thank you, sir, to all the
Thank you, sir.
eminent speaker as well as the panelists. Though we have few questions with us, but they are more or less been addressed during the discussion with the eminent faculties. So on behalf of Hetero Healthcare, I'll thank each one of the delegates. Though just to give a numbers, we have nearly 197 audience being present during
Oh, very
the
good, very
talk.
good.
That is
Yeah.
there. And I'll thank Dr. Saple for giving his valuable insights as well as the thing. To Dr. Verma, the Professor HOD Manipal Hospital, KMC Manipal, from Department of Infectious Disease, to Dr. Sebastian, the Senior Resident from KMC Manipal, Dr. N. Shantanam, the DMID from Velamal Medical College, Madurai, to Dr. Pasha from Nasik, DM Infectious Disease Specialist, and to all the delegates who have attended this excellent case discussion based things. Though in the midst of the time constraint, we couldn't able to take up the question, but I think most of them were been addressed by the eminent faculties during the course of discussion. With that, I conclude this webinar and thank to all the faculties for giving their valuable time and sharing their thoughts on the management of the important cases which were being shared by all the three faculties, as well as with Dr. Saple, and more importantly to Dr. Verma for giving his insights in terms of managing these cases. So thank you on behalf of Hetero Healthcare, and good night to all of
Okay.
you.
Good night. Good
Thank
night
you.
to everybody.
Thank you.
Yeah. Good night.
Thank you. Thank you.